Hi everyone, this is Savinay here. Lecture topic is gross anatomy of male internal genitalia. The objective of this lecture is to discuss the gross anatomy of the testis, epididymis, vas deferens, seminal vesicle and prostate. Also, surgical anatomy of the prostate and the importance of its coverings. Specific learning outcomes of this lecture. At the end of the lecture, students should be able to list the different parts of male internal genitalia. Explain the parts coverings, blood supply, nerve supply, lymphatic drainage and descent of testis. Explain the parts, blood supply, nerve supply of the epididymis. Describe the extent, relations, blood supply and the surgical anatomy of vas deferens. Explain the capsule, lobes, relations, blood supply, nerve supply and lymphatic drainage of the prostate. Describe the surgical anatomy of the prostate and its capsule with its surgical importance. Reproductive system consists of a number of sex organs that play a role in the process of human reproduction. These organs are located on the outside of the body and within the pelvis. Based on their locations, male genitalia can be divided into male internal genitalia and male external genitalia. Let us see the components of male internal genitalia. It includes testis, duct system, and accessory glands. Moving to the next part, there's the different parts of male internal genitalia, which includes testis, which we can locate here, then the epididymis, then vas deferens, this is the vas deferens or the ductus deferens, seminal vesicles, ejaculated duct, around that you have prostate gland. Here we can locate the bulbourethral gland or the corpus gland. Functions of male reproductive system. The main function of male reproductive system is the production of spermatozoa. These spermatozoa are produced in the testis. The various parts of the genital tract carries the sperms to the outside or exterior. They provide maturation and nutrition to the sperms all along the tract. Accessory glands of male genitalia, besides providing the nutrition, they add quantity to the semen. The testis is a male gonad. Let us see the gross anatomy of testis. Testis is a male gonad. It is homologous with the ovary in the female. The functions of testis includes production of spermatozoa and secretion of testosterone. Shape and measurement of the testis. If you observe the shape of this testis, it is oval or ellipsoid in shape. When it comes to the measurement, the length of the testis is about 4.5 centimeter. These measurements will be taken in average form. So some books say that it is between 4 to 5 centimeter. Anterior posterior diameter, it is about 3 centimeter, and the thickness of this testis is about 2.5 centimeter. It weighs about 10 to 20 grams. The position of testis in the scrotum. So testis lies within the scrotum. It is placed obliquely. It is suspended by the spermatic cord. As I said, it is placed obliquely. The left testis lies slightly at lower level than the right because the left spermatic cord is slightly longer than the right one. Let us see the external features of testes. Testes consists of borders, that's anterior border and the posterior border, poles, upper pole and the lower poles, and surfaces, medial and lateral surfaces. So it has two poles, upper and lower pole. Let us locate this upper pole and the lower pole here in this diagram. This is the upper pole and here is the lower pole, and this upper pole provides attachment to spermatic cord. The testis consists of two borders, anterior border and the posterior border. The anterior border we can locate here. This is the anterior border and this one is the posterior border. The anterior border is rounded and completely covered by tunica vaginalis. This is the outermost covering layer of the testis. And posterior border is straight and tunica vaginalis is partially covers. That is because between these two structure, that is the tunica vaginalis and this posterior border of the testis, you can find another structure here, that is the epididymis. The testis consists of two surfaces, lateral surface and the medial surface. In this diagram you can see the lateral surface. The medial surface is not visible, it's on that side. On the lateral aspect, the epididymis is separated from the testis by a sinus, which is the extension of cavity of the tunica vaginalis. The sinus is called sinus of epididymis. The sinus of epididymis plays major role in determining the lateral surface from the medial surface in cadaveric specimen. Coverings of testis. The testes are enclosed in a tough capsule made up of three layers. From superficial to deep, these are tunica vaginalis, this is the outermost layer. Deeper to that, tunica albuginea. Deeper to that, tunica vasculosa. So tunica vasculosa is the innermost layer. Outer to that we have tunica albuginea, and the final one is the tunica vaginalis. Tunica vaginalis is a serous sac. Tunica albuginea is made up of collagen fibers, and tunica vasculosa is made up of blood vessels. Here we have a cut section of the scrotum along with the testis. Now here we can locate the anterior part of the scrotum. This is the posterior part of the scrotum. We can see the different covering layers of the scrotum or the layers of the scrotum, and here we can locate the coverings of the testis. So coming to this diagram, here we have skin, then we have external spermatic fascia, then we have cremasteric muscle and fascia. Inner to that we have internal spermatic fascia. Inner to this we have this layer. This is the tunica vaginalis, which consists of outer parietal layer, inner visceral layer. Deeper to this we have tunica albuginea, and deeper to that you can see the red color one, which is made up of blood vessels, that is the tunica vasculosa. The outermost covering layer of the testis is the tunica vaginalis. Tunica vaginalis is a serous sac representing the persistent lower portion of the processus vaginalis. This is the tunica vaginalis. It is invaginated by the testes from the behind. It presents two layers. The layer which is lining the testis or the tunica albuginea, that is the visceral layer, and the outer layer is the parietal layer. Both these two layers continuous at upper pole and the lower pole. Between these two layers you have potential space that is called cavity, which is filled with the fluid. When there is accumulation of excess fluid in this cavity, that condition is called hydrocele. Clinical correlation of the tunica vaginalis. As I mentioned, between two layers of tunica vaginalis we have potential space. This potential space normally occupied by thin film of clear straw colored fluid. The volume of this fluid can increase with the obstruction of lymphatic drainage due to inflammatory, traumatic or neoplastic condition of the testis. That results in hydrocele. The hydrocele is the accumulation of fluid within the tunica vaginalis. You can see here the accumulation of fluid within the tunica vaginalis. The fluid may collect following the inflammation of testis because tunica vaginalis is closely related to the front and side of the testis. But most hydroceles are idiopathic. Idiopathic means the cause is unknown. Moving to the next layer, there is the tunica albuginea. Tunica albuginea is a thick, dense layer of fibrous tissue enclosing the testis. It is made up of collagen fibers. Its posterior border is thickened to form incomplete vertical septum that is called mediastinum testis. Numerous septa extend from the mediastinum to the inner surface of tunica albuginea. These septa divides the testis into 200 to 300 lobules. Next layer is the tunica vasculosa. This layer is the innermost layer and it is lined by the blood vessels. So it's a vascular layer of the testis. And this layer also line the lobules of testis. So here we have a transverse section through scrotum and testis. We can see the layers of the scrotum here as well as coverings of the testis. The outermost layer of the scrotum is the skin of the scrotum. Deeper to that you have fatty layer and it is dartos fascia, and deeper to that we have external spermatic fascia, then cremaster muscle with the cremasteric fascia, internal spermatic fascia. Go deep, we have first outermost layer of the testis, that is the tunica vaginalis. Deeper to that this white color structure, that is the tunica albuginea. This tunica albuginea sends septa to the mediastinum, divides this testis into different lobules like around 200 to 300 lobules, and the innermost layer which is near to this area, that is the tunica vasculosa. Tunica vasculosa lines the lobules, and here we can locate the mediastinum. It is a thickened part of the tunica albuginea. This is our posterior aspect here, and we can look at the body of the epididymis here on the posteriorly, and along with that you can see the vas deferens and femtoriform plexus, arteries, everything. Let us see the internal structure of testis. It consists of septum or septa, seminiferous tubules. Between two septa you have a lobule. Two to four seminiferous tubules joins to form straight tubule. We can locate the straight tubule here, and you can locate the efferent ductules here, which are arising from the rete testis. This rete testis is formed by the different straight tubules. Testis is covered by tunica albuginea. It's an intermediate layer which is made up of collagen fibers, white in color. Posteriorly, this layer is thickened to form mediastinum testis. This is the mediastinum testis. In this mediastinum testis, you can locate the network of delicate tubules that is called rete testis. These are formed by the straight tubules. This mediastinum testis sends septa to tunica albuginea. In turn, it divides the testis into 300 lobules. Each lobule has 2 to 4 seminiferous tubules. Let us locate the lobule here. Now we have septa here. This is one septum, two septa. Between two septa, you have one lobule. Each lobule consists of coiled structure here, that is the seminiferous tubules. They are 2 to 4 in number. These seminiferous tubules are lined by multilayered epithelium. They are responsible for the production of spermatozoa. The seminiferous tubules join to form 20 to 30 straight tubules, which we can locate here. This is the straight tubule. These are the straight tubules. These straight tubules join to form rete testis. Straight tubules anastomoses to form rete testis. In this picture, we can locate the rete testis here. This is the rete testis. There is about 12 to 30 efferent ductules arise from the rete testis. You can see these ductules, efferent ductules. So this is the enlarged diagram of the testis. Now here we can look at different layers, covering layers of the testis. This is the outermost covering layer, is the tunica vaginalis. Now inner to that you have tunica albuginea. You can see the tunica albuginea. This tunica albuginea is thickened on the posterior aspect to form mediastinum testis. Okay, and from this mediastinum testis to the tunica albuginea you have fibrous septa. So the fibrous septa extending from the tunica albuginea reaches to the mediastinum, divides this testis into different lobules. So each lobule will have 2 to 4 seminiferous tubules. These seminiferous tubules will join to form straight tubules, and this straight tubule anastomoses each other, forms the rete testis. Rete testis. From this rete testis you get the efferent ductules. You can see the efferent ductules here. Efferent ductules here. The efferent ductules emerge from the upper end of the mediastinum. Let us see that part here. So here we have efferent ductules. They are emerged from the upper end of the mediastinum testis. Mediastinum testis. So they are coming from the rete testis. There are 15 to 30 in number. They are 15 to 30 in number. The efferent ductules open into single duct of the epididymis. This is the epididymis, which consists of different parts. We will see later. The blood supply of the testis includes arterial supply and venous drainage. Arterial supply of the testis mainly by the testicular artery. The testicular artery is a branch of abdominal aorta. You can see the abdominal aorta here. This is the testicular artery, right testicular artery and the left testicular artery. These arteries descends on the posterior abdominal wall to reach the deep inguinal rim, where it enters the spermatic cord. Then it passes along with the spermatic cord. At the posterior border of the testis, this artery divides into branches to supply the testis. Testis also receives blood from cremastic branch of the inferior epigastric artery, which once again runs along with the spermatic cord. You can see here this is the cremastic artery. Then we have another artery here, that is the artery to vas deferens. The cremastic artery is a branch of inferior epigastric artery, and the artery to vas deferens is a branch of superior vesical artery. Superior vesical artery is a branch of internal iliac artery. Venous drainage of testis. The pampiniform plexus of veins drains the venous blood from the testis. The pampiniform plexus, they are the network of veins. Pampiniform means convoluted, plexus means network. Here we can locate these pampiniform plexus. These plexus are formed by the veins arising from the testis. This pampiniform plexus, as they ascend upward, they will condense into 4 veins at superficial inguinal ring and into 2 veins at deep inguinal ring. Finally, they drains into inferior vena cava on right and left renal vein on the left. Now let us see the clinical correlation of the pampiniform plexus. There is a condition called varicocele. It is a clinical condition with which veins of pampiniform plexus become dilated, tortuous and elongated. Usually it happens on the left side. It is because of the course of the left testicular vein, which makes an acute angle before it drains into left renal vein. So here in this diagram you can see the dilated veins of the spermatic cord, and this testis is normal. And when you see over the scrotum, the varicocele can be felt and sometimes be seen as a tortuous mass on the surface of the scrotum. The testis is innervated either by nerve fibers that arises from the 10th and 11th thoracic spinal segments via renal and aortic plexus and accompany the testicular vessels, or by the fibers arises from the pelvic plexus and accompany the vas deferens. Some afferent and efferent nerves have been shown to cross over the contralateral pelvic plexus, which may be one of the reasons why pathological processes in one testis can affect the other. Lymph from the testis drains into tree and para-aortic lymph nodes. These lymph nodes are around the abdominal aorta. Descent of testis. Now, initially the testis is formed in the abdominal cavity. Testis develops in the lumbar region at the level of T10 to T12 in intrauterine life. Each testis begins to descend during the second month of the intrauterine life. They start descent. At the third month, it reaches the inguinal fossa. It reaches the inguinal fossa here. It rests at deep inguinal ring from 4 to 6 months. So it rests on the deep inguinal ring from 4 to 6 months. Then it passes through the inguinal canal. It passes through the inguinal canal at the 7th month. It reaches the superficial inguinal ring at 8th month and to the scrotum by the 9th month. Applied aspects of testis. Cryptorchidism is an anomaly, that means undescended testis. The descent of testis may fail to occur or may be incomplete. The organ may lie in the lumbar region or may lie in the iliac fossa, inguinal canal, or in the upper part of the scrotum. Anarchism, absence of both testes. If there is absence of one testis, then we call it as monarchism. Another important anomaly of the testis is ectopia testis. That is the abnormal positions of the testis. The testis may lie under the skin of the lower part of the abdomen, under the skin of the front of the thigh, in the femoral canal, under the skin of the penis, in the perineum behind the scrotum. Here we can see perineal ectopia testis. We can locate this testis here. The testis emerging at the subcutaneous inguinal ring slips down between the scrotum and thigh and comes to the rest in the perineum. So another clinical condition of the testis is a torsion of the testis. It is a clinical condition in which rotation of testis occurs around the spermatic cord within the scrotum. Moving to next component of male internal genitalia, that is epididymis. The epididymis is 4 to 6 meters long, is highly coiled structure. You can see it is highly coiled. The shape of this epididymis is somewhat comma shape. It consists of head, body and tail. The tail continues as ductus deferens or the vas deferens. This is the vas deferens. The main function of the epididymis is the reservoir of spermatozoa. The testicular fluid which is produced in the testis will be reabsorbed in epididymis. Coming to the arterial supply of the epididymis by the testicular artery. This artery supplies to the testis also. Venous drainage, it is similar to the testis. It forms the falciform plexus, then forms the testicular vein. They finally drain into the inferior vena cava on the right side and left renal vein on the left side. Nerve supply. It is from the sympathetic nerves through testicular plexus. The root value or the preganglial fibers arises from the T11 to L1. The next important component of male internal genitalia is the vas deferens or the ductus deferens. It is a tubular structure. Its primary function is the transport of sperm from the epidermis to the urethra. Ductus deferens or vas deferens. It is a muscular duct. The wall is very thick. Let us see this ductus deferens in this picture. This is the epidermis. The tail of the epidermis continues as ductus deferens. This later ductus deferens joins with the duct of the seminal vesicles to form ejaculatory duct. The length of this duct is about 45 centimeter long. It extends from the epidermis to the ejaculatory duct. It begins at the inferior pole of the testis. It is a continuation of tail of the epidermis. It passes in the posterior part of the spermatic cord, traverses in the inguinal canal. From there it reaches the deep inguinal rim. In greater pelvis it hooks around this artery. There is the inferior epigastric artery. In the lesser pelvis it runs downward and backward on the lateral wall of the pelvis. Then it reaches the base of the urinary bladder. It joins with the duct of the seminal vesicles to form ejaculatory duct. So you have seminal vesicle here. It joins with the duct of the seminal vesicles to form ejaculatory duct. Blood supply of the vas deferens. The arterial supply of the vas deferens is mainly by the branches of superior vesical artery and also from the inferior vesical artery. This vesical artery is mainly supplies to the urinary bladder, also it supplies to the vas deferens. The venous drainage. The venous blood from the vas deferens drain into vesical venous plexus which opens into the internal iliac vein. Surgical anatomy of vas deferens. Vasectomy. This is a common method of male sterilization where short segment of each vas is excised or cut. The cut ends are crushed and ligated. The vas differentia are approached to a median incision in the upper part of the scrotum below the penis. In this slide, you can see different steps involved in the procedure of the vasectomy. Here we have first step, the identification of the vas deferens. The second step is the injection of the anesthesia of the skin. Third step, incision of the skin. The fourth step, the separation of the vas deferens from the other tissue with the help of needle. Fifth step, clamping of vas deferens and cutting the part of the vas deferens, that segment of the vas deferens. Then the cut end will be tied. The last step, the scrotum elevated to permit the tied ends of the vas to retract into original position. The seminal vesicles. Seminal vesicles are two tubular glands lies posterior inferior to the urinary bladder. It lies between the urinary bladder and the rectum. The length of this seminal vesicle is about 5 cm to 10 cm long. Each gland forms an outpocketing from the wall of the ampulla of the vas deferens. Okay, duct of the seminal vesicles opens into vas deferens to form ejaculatory duct. The seminal vesicle secretes significant portion of semen and concerned with the nutrition of spermatozoa, and the secretion is alkaline in nature. So here we have ejaculator duct. It is about 2 centimeter in length. It is formed by the union of vas deferens and the duct of the seminal vesicles. They enter and pass through the prostate and empty into the urethra. Moving to next component, that is the prostate. Prostate is a globular fibromuscular gland. So it is a male gland. You can locate it here. It is pyramidal shape. As I said before, it is a fibromuscular glandular organ which surrounds the prostatic urethra. The prostate gland secretes acid phosphatase, fibrinogen, citric acid, amylase, prostate-specific antigen, and prostaglandins. Now coming to the size and the shape of this prostate gland. If you see the shape of this prostate gland, it is inverted conical shape. Here we have the base, here we have the apex. The weight of this gland is about 3 grams. Width at the base is 4 centimeter. Length is 3 centimeter and thickness is 2 centimeter. So here we can see the sagittal view and this is the posterior view. In the sagittal view we can locate the prostate gland here, urinary bladder here. Here we can locate the prostate gland and this is urinary bladder, seminal vesicle with the vas deferens. So prostate consists of base, this is the base, here this is the base, and apex, this is the apex here and this is the apex here, pointed one, and it has 4 surfaces. Anterior surface we can locate here and in this picture it's not visible, and this is the posterior surface. So this one is the posterior surface, and either side we have inferolateral surface, 2 inferolateral surfaces. Relations superiorly means it is related to base. The base of the prostate is continuous with the neck of the urinary bladder. Urethra enters the center of the base of the prostate. Inferiorly, the apex of the prostate lies on the upper surface of urogenital diaphragm. Anteriorly, prostate is related to pubic symphysis separated by extraperitoneal fat. Again, here we have puboprostatic ligaments in this fat. Posteriorly, the prostate is closely related to anterior surface of the rectum and is separated from it by the rectovesical septum. Lateral side, on either side you have side walls of the pelvis. These walls are formed by the levator ani. Let us see the relations of prostate gland in picture. We have 2 figures here. This is the sagittal view and this one is the coronal view. In the sagittal view we can locate the prostate gland here. This is the anterior surface of the prostate gland, this is the posterior surface of the prostate gland, and here it's the base of the prostate gland, it's the apex of the prostate gland. The inferolateral surfaces we cannot make out here, but we can see the inferolateral surfaces here. Now let us see the relation of the base of the prostate, that is the superior relation, which is related to urinary bladder and the urethra. Here we can look at the neck of the urinary bladder and which continues down with the prostatic urethra, and the apex of the prostate gland related to urogenital diaphragm. This is the urogenital diaphragm. Now anterior surface of this prostate gland is related to pubic symphysis. Between the pubic symphysis and the prostate you have space. That space is called retropubic space of Retzius, which is filled with extraperitoneal fat. Between this pubis symphysis and the prostate gland, you have ligaments. That is, these ligaments are called puboprostatic ligaments. You have medial and lateral puboprostatic ligaments. Now, when it comes to posterior surface, the posterior surface of the prostate gland is related to rectovesical fold and also fascia of Dedovilus. And go back, you have this structure, that is the rectum. This is the rectum. Now coming to the inferolateral surface, we can look at the inferolateral surface here, which is related to the levator ani muscles. This levator ani muscles forms the lateral wall of the pelvis. The next part is the capsules of prostate. The prostate is covered by two capsules. Capsules are nothing but the covering layers. So here we have two capsules. One, the innermost one, true capsule. The outer one is the false capsule. We have false capsule and the true capsule. In a true capsule lines the prostate gland. It is formed by the condensation of peripheral part of the gland. It is fibromuscular in structure and it is continuous with the stroma of the gland. It contains no venous plexus. So here we have outer false capsule. This is made up of pelvic visceral fascia. On the either side of this fascia, we have prostatic venous plexus embedded in it. So this prostatic venous plexus are very important for the surgeons during the surgical approach to the prostate gland. So if any damage to this venous plexus can result in profuse bleeding. Let us see the clinical correlation of these capsules. The capsule should not be disturbed in surgery as it will lead to heavy bleeding. The prostatic plexus communicates with the internal venous plexus and these are valveless. Cancer can spread to brain without blood passing through the heart. The prostate is incomplete divided into 5 lobes. Anterior lobe lies in front of the urethra and is devoid of glandular tissue. Median or middle lobe is situated between the urethra and ejaculatory duct, which is rich in glands. Posterior lobe is situated behind the urethra and below the ejaculatory duct, also contains glandular tissue. Right and lateral lobes lies on the either side of the urethra, which also contain many glands. Lobes of prostate. Anterior lobe lies in front of the prostatic urethra. Medial lobe lies up between the upper part of the urethra and the ejaculatory duct. Posterior lobe lies below the ejaculatory duct and behind the urethra. On the either side of the urethra, you can see lateral lobes. Okay, now come to the structural zones of the prostate gland. The prostate gland basically made up of glandular tissue and the fibromuscular stroma. The glandular tissue may be subdivided into three distinct areas like central zone, transition zone, and peripheral zone. Here we can locate the central zone. The central zone is around the ejaculatory duct. Okay, then if you see the upper part of the prostatic urethra, in the middle, around that and in front, you can locate the central zone. Below the ejaculatory duct and lower part, around the lower part of the prostatic urethra, we can locate the peripheral zone and it is partly deficient in the anterior part. So area in front of the prostatic urethra and the central zone and part of this peripheral zone is filled with the fibromuscular tissue. So that is the fibromuscular stroma. The benign prostate hypertrophy occurs in transitional and central zone. So we have transitional here and the central zone. And prostate cancer occurs in the peripheral zone. That's why these zones are very important for the clinicians. Okay. Now the structures within the prostate. This is the prostate gland. Within the prostate gland you can see this structure. This is the prostatic urethra, the part of the urethra, prostatic part of the urethra. Within the prostatic part of urethra, or the posterior wall, you can see one longitudinal ridge. This longitudinal ridge is called urethral crest. When you trace down this longitudinal ridge, you can see a bulged area that is called seminal colliculus. On the seminal colliculus, you can see a blind opening that is prostatic ventricle. In the lower part and lateral to this prostatic ventricle, you have opening of ejaculatory ducts. Either side of this seminal colliculus and the urethral crest, you have prostatic sinus. Over the prostatic sinus, you can see the openings of prostatic ducts. Now we had seen the structures within the prostate gland. The prostatic urethra traverses the gland vertically. There is a longitudinal ridge called urethral crest. In its lower part, there is a swelling called seminal colliculus. On it, there are openings on the either side for the ejaculatory ducts, and blind opening in the central is called prostatic ventricle. On either side of the urethral crest, there is a fossa called prostatic sinus, and the prostatic ducts open here. Age changes in prostate. As age advances, there are a lot of changes takes place in prostate gland. In childhood, the prostate gland is small and it is composed mainly of fibromuscular stroma and rudiments of ducts. At puberty, there is a sudden increase in the size of the gland under the influence of male hormone, that is the testosterone, and also there is increase in the duct system. During third decade, the follicles increase in size with the infolding of epithelium. During 30 to 40 years, size remains constant but infolding are lost and becomes regular. After 45 years, either undergo hypertrophy or atrophy because of hormonal imbalance. Okay. The arterial supply of the prostate. The prostate receives blood supply by the branches of internal pudendal arteries, inferior vesical arteries, and the middle rectal arteries. These branches form subcapsular larger outer subcapsular plexus, and periurethral inner periurethral plexus. Venous drainage of prostate. The veins from the prostate form rich plexus around the sides and the base. These venous plexus are the prostatic venous plexus, which lies outside the capsule of the prostate. The prostatic venous plexus receives the deep dorsal vein of the penis and numerous vesical veins and drains into internal aortic veins. So in this picture we can look at different organs. Here we can look at the prostate, and this is the urinary bladder, this is the pubic symphysis, and here we have penis, and this is the scrotum with the testis. Now when you look into this organ, this is the prostate. Around the prostate you can see the venous plexus. These venous plexus are called prostatic venous plexus, and here we have urinary bladder, we have vesical venous plexus, and this is the deep dorsal vein of the penis. So this prostatic venous plexus receives the deep dorsal vein of the penis and the vesical veins or the venous plexus. Then all together they finally drain into internal iliac vein. Prostatic venous plexus has communication with vertebral venous plexus, and this communication is valveless, through which the prostatic carcinoma can spread to the vertebral column and the skull. The lymphatics from the prostate drain into internal iliac lymph nodes, internal iliac lymph nodes, external iliac lymph nodes, and sacral groups of lymph nodes. Now supply of prostate gland. The prostate gland is supplied by sympathetic and parasympathetic nerve fibers. The sympathetic supply is provided by superior hypogastric plexus. The fibrin fibers arises from L1 and L2 spinal segments. Parasympathetic nerve supply is provided by pelvic splanchnic nerve, which convey the preganglionic fibers from S2, S3, S4 spinal segments. So here in this diagram we can see superior hypogastric plexus. The fibers are coming from L1 and L2, then they join with the inferior hypogastric plexus. Okay, so from there it supplies to the prostate gland, and here we can locate the pelvic splanchnic nerves. The fibers, preganglionic fibers, are arising from S3, S4, S5. Now let us see the applied anatomy of prostate gland. The benign prostatic hypertrophy, that is enlargement of prostate gland due to hypertrophy of median lobe forming an adenoma, usually occurs after 50 years of age. It commonly involves median lobe, which compresses the prostatic urethra and obstructs urine flow. Prostatic carcinoma, commonly found in the outer zone, that is the peripheral zone, which is more glandular, usually involves the posterior lobe. Clinically it presents as pain in perineum, urinary obstruction, difficulty in urination. Moving to the next part, that is the surgical anatomy of the prostate. The removal of prostate is called prostatectomy. That can be partial removal of the prostate gland or complete removal of the prostate gland. This surgical approach is to treat the prostate cancer. During the removal of such gland is enucleated, leaving behind both capsules and venous plexus between them. In the most common type of prostatectomy is radical retropubic prostatectomy. You have different types of prostatectomy you are going to study in the later classes in the surgery. So for this retropubic prostatectomy, the incision is made in the abdomen and the prostate is removed from behind the pubic bone. If you have any questions or queries, you can message me in the LMS platform or through the WhatsApp. Thank you very much. Have a great day.